Hello, everyone. Good day, good day. Welcome to today's event. I'm David Voss. I'm HUD's Director of the Office of HIV/AIDS Housing. And let me welcome you today and recognize this week World AIDS Day. We're a couple days early, but this is the new HUD where we're always the first to get things done. So I want to welcome you to today's event. We have a really great panel to talk about projects across the country, and we'll be up shortly. But I'm very privileged to have the team of people here, we'll call our senior team, people who've been working in the field that's important to us, how we use our community planning development resources to make a difference in America's communities, how we work in the Department of Health and Human Services to broadly think about how we help people get health outcomes that are good, especially when in our field, people with HIV/AIDS. And of course, the leader of the National AIDS Strategy, Jeff Crowley, the director of the Office of AIDS Policy at the White House, who are very privileged to have joined us again here at HUD. Thank you, Jeff, for making the journey today. As I said, this is a recognition of World AIDS Day. It's a recognition of some things that HUD can do to make a difference, and hopefully you know in your work that all parts of our program have an important role to play, either directly like the programs in CPD that help people with AIDS, or more indirectly, public housing, our planning, our use of budget dollars accountably, even just how you care and involve your neighbors in this work. There are two numbers I want to talk about today. One is that last reporting period, 16,605 Americans died because of HIV/AIDS and AIDS complications. You know, this epidemic still takes the lives of people. And importantly, though, it doesn't have to. If people are in care, I think the outcomes are really different. The outcome, the prospect of people stably in care, taking medications when that's appropriate, the lifespan is almost identical to the normal lifespan if the care is appropriate. And so what we see is terrible disparities of people who are not in care. And we want to change that, and we want to make sure people have equal access to care. And again, that's another reason the HUD programs play such an important part, because stable housing really helps equalize the field to improve that access to care. The other number is that over 200,000 Americans are living with HIV, but they don't know it. So they don't know, and hopefully they're not doing things, risky behaviors, but they don't know to take extra precaution. And that's another story that we've seen from the research, that people who know their status really change the activities and really help us reduce the spread of HIV, because they're aware, they're doing things about that. If they're in medications also, the data now shows that the reduced risk of transmission of HIV are tremendous, 96% or some number of that scale. So it's very important, again, that we think about our programs, that there are 200,000 Americans who should be tested and brought into care, even if the care is just monitoring the situation and not actually being on medications. So those numbers are among the many numbers that come to the world of AIDS, because AIDS has a lot of statistics about it. And you know, the main thing is, again, it's about a person, it's about a family, it's about a neighborhood, and about a community. And fortunately at HUD, we have resources that can reach at all those levels. You know, we have case managers who can help support our clients understand their issues and get through difficulties. We have program planners, and many of them are joined us today in this special session. We are privileged to have awarded 7 new grants, and we'll be hearing from them shortly. But again, HAPWA, the program that we are privileged to work on in the Office of AIDS Housing, Housing Opportunities for Persons with AIDS, is a leading program, but it's not the only program. And we are successful because we partner with other successful programs at HUD and other programs in the Office of Community Planning and Development. And as the managing leader of our Office of Community Planning and Development, I want to welcome to the stage Cliff Taffet, the General Deputy Assistant Secretary, to welcome us to this event today. Thank you, Cliff.
Hello, everyone. Good to see you. Thank you for coming. I just want to take a moment at the outset to thank David and Mark Johnston, who's the DAS over special needs. These are two of the most dedicated public servants you could hope to work with. It's a privilege all these years having worked with them and learned from them. We always need mentors, and in a sense, they've been my mentors. On behalf of Mercedes Marquez, our Assistant Secretary, I'd officially like to welcome you, now that I've gotten those niceties out of the way, and launch this discussion today, Uniting for Action, a forum for cross-program approaches to HIV. First, I'd like to recognize our honored guests. They've got so many degrees, I won't even go there, but Jeff Crowley, who is Director of the White House Office of National AIDS Policy and Senior Advisor on Disability Policy, and Dr. Andrew Forsyth of the Department of Health and Human Services in the Office of the Assistant Secretary for Health. On the issues related to AIDS, none of us can afford to be bystanders. We need to be engaged, involved, and be sure that our voices are heard. This week, the world is commemorating 30 years of struggle with AIDS, but we're also celebrating the many advances in care and treatment and prevention that have been developed in response. At HUD, we have several housing programs that have assisted folks with AIDS, including one especially targeted for that purpose, Housing Opportunities for Persons with AIDS, or HOPWA. And HOPWA represents a partnership in the true sense of the term. Over the past 20 years, HUD staff and headquarters and in the field have worked closely and in collaboration with our community partners, helping to change the reality and the outcomes for persons living with AIDS across this country. In the coming year, we expect to work even more closely with our partners to better deploy our resources. We're going to be using census data and the new American Community Survey to help identify areas where our programs are working and find out where our programs are not as good as they need to be. We need to be careful in managing our public resources. You may have taken note of the fact that our resources are not growing. In fact, they're shrinking. And we have to make sure that every dollar is well expended. We're looking to our 7 new HOPWA partners, who I'd like to, again, officially welcome at this moment, to help us involve other sectors in our work, like public housing authorities and health departments and social service agencies. I want to thank you all for helping and collaborating on this effort. But today is much more than just about programs. Let's take this opportunity to think about the families and friends and colleagues who have been living with AIDS and HIV over the past several decades. They have faced great difficulties, especially those that have been homeless or unstably housed and who lack adequate care. And I'd like to also take a moment to pause and remember and reflect on those who are no longer with us, if you might. Thank you. Much has been accomplished over the years, but much remains to be done. Your voices are important. Please make them heard today and every day. Thank you again, and have a great meeting.
And thank you, Cliff, for that. It's my great privilege to introduce our next speaker. As Cliff mentioned, he serves in the administration as the Director of the Office of National AIDS Policy and as the Senior Advisor on Disability Policy at the White House. Jeff Crowley is somebody I've been privileged to work with for almost 3 years now in the area of national AIDS strategy. Because of Jeff, there were extensive hearings across the country getting to have a real dialogue with our communities. And I know in those dialogues the issues of housing was one of the prominent discussion points. Through his leadership, he pulled together our federal departments and made us talk to each other, something that I think prior to these 3 years we didn't do quite the same way. And I think going forward, we're going to have a really strong federal partnership that really was there on paper, but is now going to be there in reality. And Jeff, you contributed that. I know one of the things you've announced is that you'll be leaving your post shortly, but I think I would say maybe Secretary Sebelius said it best at the U.S. Conference on AIDS earlier this fall, where she said that your contributions were to take the federal government off cruise control, letting our programs just run, and to try to get us to put the accelerator down, to get them to run better and faster and get better results. So I think through your leadership, we are going to see that in the federal government, and thank you for that. Let me welcome you to the stage.
Thank you, David. So it's a pleasure to be back here at HUD as we commemorate one more World AIDS Day. 30 years in, we could choose to either be sad about this and say that the reality is overwhelming, or we could be hopeful. And I think that there's so much going on at this point in history that we really should lead with all the hope and excitement that we have as far as our response to the domestic HIV epidemic, but also the global pandemic. I'm not going to say too much today. I wanted to be really quick, but David did just sort of ask me to give people an update on sort of where we are with the implementation of the National HIV/AIDS Strategy. And I would say I'm encouraged to be back here and learn that HUD is holding this meeting today, and they have 7 new partners, so where really the focus is on learning about how we do some things differently and how we improve our coordination. And so I want to congratulate the new partners, but also I hope that today's a rich meeting for all of you. So just really quickly, as David mentioned, the President made a commitment to developing a national HIV/AIDS strategy. He released it a year and a half ago in July of 2010. This past summer, we sort of all started reflecting on what's been done differently? And, I have a couple of things that I think things that we can point to with pride that things are different. And, David mentioned this. I think one of the things we have done is we've reinvigorated our federal response to the domestic HIV epidemic. As I prepare to leave my position and I get a little nostalgic, I am so proud, not of what I've done in the White House, but what so many of my partners across the government are doing. I was an advocate, and so I still know how to push people and be critical, but sometimes we also need to stop and just acknowledge that we have so many people that have committed their lives and their careers to fighting the HIV/AIDS epidemic, and it's not always easy on the inside. And so I think we have a lot of people, including David and others at HUD, that are really strong leadership, and that's something I think is really important. The next thing I would say is that we fought for continued and new investments. And at HUD, I can't say we've doubled the HOPWA program, but in a really difficult environment, we protected this program and achieved modest increases, and that's something that I'd say didn't happen naturally. And so I think it's taken a lot of leadership from people at HUD and elsewhere, but that's something I think is really important. In other areas, we're trying to say this is not an environment where we're going to have lots of new resources, but what are the priorities and where can we make the most strategic investments, and we started to do that. Lastly, I would just say I think we're starting to do some of the really hard stuff. Earlier this year, the Centers for Disease Control and Prevention put out a new funding announcement for their major HIV prevention program, and it's how they fund state and local health departments. They're doing something that we said in the strategy we all need to do, and that is they're now going to allocate the funding based on living HIV/AIDS cases. This is a difficult thing to do in the CDC context. When this is fully phased in, some states will get roughly half as much money as they were before. Other places will get, maybe 50% more money than they were. It's not because we've made decisions about who our friends are and who are not. It's that we've all sort of collectively said, at a time of scarce resources, what's the fairest way to allocate funding? And we said, living HIV/AIDS cases. So we count both people with HIV and AIDS. We don't count cumulative cases that counts people who are no longer living. We count current HIV/AIDS cases. What's the best data we have to really understand the current burden of the HIV epidemic? This is a difficult thing to do, but I also think this is how we make progress. In the context of HUD, one of the commitments we've made, and HUD's been working with us on, is to say we need to make that same change in the HOPWA program. Now, in HOPWA's case, this really requires a partnership with the Congress, and we'll need legislation to get this done. But as we committed at the beginning of this year, we have been working on a plan to move forward. This, I promise you, won't be easy. It'll still be the right thing to do. So hopefully we can all come together and say, okay, we need to get to the best place at the end. There'll be challenges along the way. How can we do this in a way that really maximizes the investment? So for the Congress and the American people, we can say every dollar we're investing in these programs will have the biggest impact. But also, how can we do it in a way that does the least harm as resources are shifted around, but also gets us the biggest impact? So lastly, I would just say that, this isn't rhetoric to say that this is a unique moment of opportunity in response to the domestic HIV epidemic. And I sort of point to 3 things. We do have a strategy. And that really, I think, if we did anything together in developing a strategy, it was that we identified a clear set of priorities, not just for the federal government, but for all stakeholders. So what's the path that we all think we need to follow? We have that path now, and I think we're starting to follow it. The second thing is, and I'm sure David and others have mentioned, all this great research. This has been perhaps, except for the period when we got effective HIV treatments in the mid-90s, this has probably been the most productive and exciting time for HIV research in the history of the epidemic. You know, with the research we've seen about pre-exposure prophylaxis, with successes of the Caprisa trial with a vaginal microbicide, and then most recently, new promise on HIV vaccines, and then most recently this study that it's called HPTN 052 that showed if we tested giving people early treatment for HIV and delayed treatment, and found if we get people on treatment early, we can demonstrate a 96% reduction in transmission. So this is really exciting. Now, how do we, though, take this exciting research and put it into action? And the third thing I think is so significant coming together is, the President worked so hard to enact the Affordable Care Act. And I know you guys do housing, not health care, but I think that giving people access to insurance coverage is really going to provide a platform for making a lot of new progress. But that alone isn't the solution. One of the things that all this research has got us talking about is what this concept called the treatment cascade. Have you all heard of this before? So it's this idea that we have like 1.2 million people living with HIV in the United States, but about 20% don't know they're positive. Then we lose people because they're not linked to care, retained in care. Then once we get people in medical care, well, are all of them prescribed treatment when it's clinically indicated? So we lose some there. Those on treatment, are they getting the best treatment? Are we helping support people to adhere to their medications? At the end of the day, a pretty low percentage. Previously, there was some modeling work that said about 19% of people with HIV are maximally suppressed. This week, without saying anything, there'll be some new government analysis that provides more information about this, about this estimation. But we know that access to medications is important, but it's more complicated than that. We have to have doctors to prescribe the medications, but we also have a broader support system to get people to stay in care and stay on treatment. And that really brings us to housing and the importance of the HOPRA program, but also the other programs that HUD operates. We can keep every person with HIV alive in the United States if we do the right things. And medical care is really important, but these other services like housing are equally important. So I will just stop here and say I hope that as you commemorate this World AIDS Day, we can recognize that we have some significant challenges as a nation, but there's a lot of opportunities ahead, opportunities that are sort of a unique moment. So I hope that when we look back in 5 years and 10 years, we can say, maybe we didn't get everything right, but we started doing things differently. And that's why I think, again, this meeting with your grantees, where it's really about new approaches and new ways to coordinate our efforts, are particularly important. So I hope you have a good meeting, and thank you for all your important work.
Thank you, Jeff, for journeying through the rain to be at HUD today, and good wishes for your future endeavors, too. Speaking of partnership, AIDS is about health, and we've been privileged to work with the part of the federal government that is focused on that, the Department of Health and Human Services. Under the Assistant Secretary for Health, there's an office called the Office of AIDS Policy. Dr. Baldessari is the head of that office. But one of the key staff persons that is sort of my frequent email partner is Dr. Forsythe, Andrew Forsythe, who is the senior science advisor in the office. And on many different projects, the inventory of programs to help African Americans, the idea that there are core indicators that we should all in the federal government collect together, the collaboration with 12 large cities and communities about how their AIDS programs could be better integrated. These are things that Dr. Forsythe has worked on, and actually by inviting HUD to participate, we've I know Lauren and I had an opportunity not only to read all those documents, but to have a briefing from 12 organizations that represent 52% of the HOPRA program. And I need to talk to my grantees, and we try as much as we can, but here was an opportunity to talk with them in a way that was trying to make sense in their community on all the HIV programs working together to come a common result, to be efficient in the service delivery, and to stay focused on what the outcome is for the client, a better health outcome from that client. And I really thank you, Dr. Forsythe, and your team for allowing us to participate in that way. So let me welcome you to the stage.
Thanks, everyone. It's a real pleasure to be here. I am Andrew Forsythe from the Office of HIV/AIDS Policy, and Dr. Ron Valdesari does send his regards. It's nice to be here with you today. Let me just echo some of the things that David and Jeff just mentioned a few minutes ago. It's an incredible time. The scientific advances are coming in day after day, or so it seems. Every 6 months, there's some major advance in HIV prevention, treatment, and care science that just blows me away as somebody who's been involved in this field as a researcher, as a program officer, and now as a policy person. It's just been incredibly exciting to see. In fact, just last night as I was doing a little bit of homework, getting prepared for today, I noticed that there's a brand new publication that's just out. Many of you may have seen this by Mary Hawk and her colleagues in Pittsburgh that shows that not only is it feasible to get people connected who are homeless to housing services, but it also very clearly improves their health outcomes. They were able to demonstrate that, unlike in other parts of the country here where the people fall out of the treatment cascade so much so that only 19% or so of folks actually make it to viral suppression. By hooking people up with good quality housing services, they're actually to demonstrate by measuring viral load that 69% of people who are provided housing services are able to make it to the viral suppression level, which is critical. This is a huge piece of information that hopefully may be relevant to some of the work that you do here. I was asked to just provide about 10 minutes of an overview of some of the work that we do, and I'll be happy to do so. What I'll do is just talk very briefly about the strategy itself, the national HIV strategy, something that I know you probably have committed all to memory. I'll also say a few things about the lessons that we learned from the 12 Cities project, and I'll just say a word or two about those to put them into perspective. For those of you who haven't committed the strategy, the National HIV/AIDS strategy to memory, it really does focus on three main strategies. The first has to do generally with reducing new infections. The second has to do with improving access to and outcomes of care, a very important issue as we've heard already this morning. And the third has to do with reducing HIV-related health disparities, and that's operationalized in the strategy in a very specific way, and that is by increasing by 20% the number of men who have sex with men, African Americans, and Latinos who achieve viral suppression. There's a fourth target in the strategy that many people do not know about, or they haven't given as much attention to, and that's for good reason. That's really the purview of our shop at OHAP. There, the fourth strategy is to achieve a more coordinated response across the federal government and between federal, state, and local and tribal governments, and to improve monitoring and evaluation and reporting on progress toward NHAS goals. Now this for us in OHAP is central to what we do. It's a huge part of the interactions that we have with our various partners, including David Voss and Lauren D. and others here at HUD, who have been tremendous collaborators, I have to say. It's really been, for me, somebody coming from science to policy, really exciting. But let me tell you a little bit about how that coordination plays out for us at OHAP. Many of you are familiar with the with ECHIP. This is the Enhanced Comprehensive HIV Planning Initiative that CDC released, I think it was in 2011. And they launched this as a 3-year project that would target 12 of the metropolitan statistical areas, as you all know, that had the highest AIDS burdens according to data that they had in 2007. They implemented this program, or they built this program on several key principles that I'm really thrilled to say made it into the new HAPWA, or perhaps informed some of HAPWA's thinking with its new initiative. So let me just share some of these with you. ECHIP specifically sought for applicants to conduct comprehensive assessments of available services, to look around at what's in the MSA, and to at least document what's available in terms of HIV treatment, prevention, and care services. It then encouraged people to direct sources, as we heard David say earlier, to achieve the maximum impact. That is, to use the data, the resources that we have now, recognizing that in this tough economic climate, that may change. But the challenge was, how do we make the most? How do we optimize the resources that are available? And this wasn't just looking at CDC's resources, but looking across the federal government, those agencies that provide HIV prevention, treatment, and care services. It then included something that I think is really, for me, is revolutionary. It's really, really worth applauding, and that is, it really sought to improve data-driven resource allocation. That is, once you get a sense of everything that's in the MSA, start to do some modeling in some cases to try to find ways to optimize those available resources. So for example, if you have $100, where do you put 80% of that, or 50% of that, or 30% of that to have the greatest possible impact? And as a result, the modeling studies that were embedded in some of the eChip projects were really stellar, and I thought were very much cutting edge. The fourth and fifth things that I think was really important about this process for eChip was that it encouraged people to complete these situational analyses and then to develop an implementation plan that would breathe life into those modeling exercises. They would find a way to put those resources to best use in those jurisdictions. And as you know, 12 of those jurisdictions were funded last year. That first planning year has been completed. Folks are reapplying now, I think it is. I don't know if there's somebody from CDC here who can speak to the process, but it's really exciting to know that many of those jurisdictions are now gearing up to implement those very data-driven implementation plans that they came up with as part of eChip funding. Now, the parallel here, I think, is really quite something. But before I go into that and compare some of what we saw in eChip to what we're seeing now in the HUD initiative, let me just tell you a little bit about what we learned in the process of pulling together those different eChip applications. As you'll remember, this was a CDC initiative, but what HHS did was it came in behind it and it said, okay, let's see if we can arrange not just CDC's resources, but all the federal government that, again, provides HIV prevention, treatment, and care services. And is there a way that we can leverage these resources to really focus them in a way that creates the biggest bang? We had a meeting after everybody pulled together those applications, and these were debriefing sessions of sorts, and David was kind enough to make time to join those. And we heard from the applicants some really key lessons, some of which aren't going to be so new here for this crowd, I realize, but improving federal coordination was consistently raised for us at every one of those 12 debriefing sessions. They really saw the importance of enhancing coordination and collaboration, not just at the federal level, again, across HUD, HHS, the Department of Justice, Social Security, et cetera, but also within the federal units, so the operating divisions at HHS, for example, CDC, SAMHSA, NIH, et cetera. They thought it was critically important that folks provide technical assistance to help them with some of the modeling exercises that they did. In fact, we helped to put folks in touch with academic researchers who are experts in modeling. There was a fantastic project or application that came out of the Maryland group that really took good use of the current technologies in modeling and resource allocation. And then another important lesson for us was the need to facilitate or to provide technical assistance, similar to the modeling work, that would help people to develop really informative plans that were relevant to their jurisdictions. I just want to highlight that you know, this was a really exciting process. It was very interactional. Again, we were very pleased to have many of our federal partners at the table, including representatives from HUD. And I was thrilled then, in May, I think it was, when the HOPWA initiative was released. It was phenomenal from my perspective. As you all know, it sought to advance HUD's implementation of the National HIV/AIDS Strategy, of course, but also the Opening Doors Strategic Plan, which for us was very much on our wavelength too. We wanted to find a way to be able to achieve both these goals. And for us, it was really exciting to see that it not only provides direct housing assistance and service delivery to low-income persons and their families, but that it also fosters a comprehensive planning and coordination strategy that, again, help to optimize resources, to put those resources where they're needed most, to have the greatest impact. So for me, this is a recurring theme, and again, we really have to credit, in my view, Jeff Crowley and his colleagues at ONAP for helping to put all of this into motion, for getting us at the Fed to really start thinking not only within our own territories, but also across the areas in which we work, and to find ways to develop new partnerships that can make the best use of the available funds. So for me, again, it's not just exciting because of the science, but it's really thrilling to be a part of this process and to try to make this move forward with all of our federal partners. So let me wrap up by saying that, again, it's an exciting time, not just in terms of science, but also in terms of policy. We have heard of the new treatment as prevention science that's coming out. We've heard now of some very compelling housing data that tells us about the importance and uses biomarkers to gauge the importance of linking people to housing services. We know that it's important to use evidence-based planning and implementation, and we see new models for ways of doing that. And we're also seeing lots of exciting progress in terms of data sharing. We've heard about using census data. We've got a number of calls that are playing out in the background between CDC, SAMHSA, HRSA, and others to think of ways to share the data that we all collect, not to mention to harmonize those in important ways. So it's a thrilling time. It feels like we're finally really beginning to focus good attention on the epidemic as it manifests here at home. So with that, let me go ahead and wrap up. Let me thank you for being here, and I hope you have an exciting meeting. I suspect it really will be one that you'll remember. Thanks a lot.
Well, we're going to take a minute here to reorganize our panelists. Thank our honored guests for speaking and joining us today. Again, thank you, Jeff. So we'll be right back with 1 second. Okay. Again, I'm David Voss, and I'm in CPD's Office of HIV/AIDS Housing. I want to thank Dr. Forsythe and Mr. Carley for joining us. And in addition to Andrew having read the NOFA and being excited, there were many communities that also read it, and many applied for the funding. And it was a national competition. We were able to select 7 based on the way HUD does business through a fair competition. But I'm really privileged to work with this group. But let me say before we start with our panel that there are some other people I'm very, very privileged to work with. And, you know, it's my work over 20 years on the HOPO program. I've often on the end of the day thought, oh, if I didn't do it, it's not going to get done. But there's a couple people who've proven that's not true anymore. And those are the people who've organized today's event. Not only the staff at the Office of AIDS Housing and our support team, but really 2 new employees in the department. Let me mention Erica Lipschultz, who did most of the logistics. And at the end of the day, I say, well, is that done? Oh, yeah, I already did that, and I did that, and it's here, it's proofed, and it's ready, it's done. And that positive energy and paying attention and being ahead of the game. I really appreciate, Erica, the graphics that you did in partnership with our graphics office and our public affairs office. And thanks to those offices, too, for helping. And again, thank you for being on top of it. The other person, Amy Polonis, who worked not only this fall on the research summit we did, but also did this program and worked with each one of these 7 grantees and on the content and worked with our TA providers. And hopefully we've already spent a couple hours this morning talking with them, learning about their communities, and they got my insight of why we did this thing and where we're going with the strategy from a HUD perspective. So I want to thank Amy, too, for being in that same well, it's already done. Here it is, ready to go, and it's in good shape. And thank you, Amy, for the leadership you showed. And my colleagues, the rest of the colleagues at the Office of AIDS Housing, and again, the HUD team that put this program together, our audiovisual people and everybody. Moving forward, you know, we have a lot of support around this program. We have technical assistance. We have Rusty Bennett from CSI and Elizabeth Malloy from VPI. We have partners in the world, advocates from the National AIDS Housing Coalition, from our people who organize our state and city territorial director divisions, and other support. But when it comes to talking about the National AIDS Strategy, those of us in the federal government hope that our ideas work. We certainly put our professional work into them to make them work. But ultimately, it doesn't work unless it happens in the community, unless it happens in a real place with real network of organizations that help clients who are in their lives dealing with this issue. And I'm really privileged to have 7 communities being represented today by these leaders. They represent organizations from Texas and California, New York, and Florida, the big places, but also from Maine and Oregon and Massachusetts. The medium-sized places. You know, and we hope to learn from them different approaches, different challenges, different things that didn't work out right, but if we do something differently, maybe we can make them work out right. And we hope to show that in these communities, the integration of AIDS housing and AIDS services and AIDS evaluation and all aspects of AIDS are better thought through, better coordinated, better thought of as a partnership in the larger sense, and not anymore as cylinders of, well, this is what I got the money for, this is the only thing I can do. It really is about the life of the client, who, after all, are people with children in school, who have families they need to deal with, and senior adults, and they have all the challenges that face many people, including all those challenges that had led them into issues of housing instability, the challenges of poverty and other challenges of homelessness, things such as substance abuse and mental health issues that challenge them, discrimination, stigma, and all those things that prevent people from being in care. And sometimes it's not even directed at them. Sometimes it's their own fear of identifying themselves as somebody living with AIDS and not seeking the appropriate care that's available. And so we hope to break down those barriers, to work to make sure people have equal access, to work, for instance, with the Department of Justice to make sure if there is issues of discrimination, we can take action. But also to actually show that in a community, it really does work. And so I'm privileged, again, to have our partners. We decided that we would make this a forum, a discussion, and we want to engage the HUD staff who are here today, and thank you for joining us today. So why don't we just go through the process, and their names are in your program. Let me start at the beginning and ask our Texas, Dallas partners, Lori Davidson, to begin. Thank you, Lori.
So I'll just,
Yeah,
great. Can you all hear me? Well, first of all, I wanted to thank HUD and the OHH staff, as well as our local HUD field office staff in Fort Worth for your support. We're really honored to be here to commemorate World AIDS Day with you all. I do want to recognize my colleagues back home because I'm definitely not in this alone. Ruben Henderson is the manager of our Project Reconnect, our reentry program, and he's here today. But also just my other colleagues at the City of Dallas and our local HUD project sponsors and planning partners, all of whom are supporting this effort. So it's definitely a team effort. Just to give a little bit of an overview of our project, it actually has two components. So one is a housing component and the other is the community planning component. From the housing standpoint, what we're going to be doing with this new SPINS grant is providing direct housing assistance to ex-offenders with HIV and AIDS, primarily those that are also receiving services under an Office of Minority Health Hire grant, as well as the Department of Justice Second Chance Act. So we're really excited to use those three funding sources to kind of provide a comprehensive approach or strategy to serve that target population. Housing is a critical need for that group, and we're very pleased to have the money for that. While the housing component really focuses on the ex-offender population, the community planning component is really a community-wide approach, including the ex-offenders, but also expands out to include more than 20 community planning partners, the Ryan White, the Hopper providers, the Homeless Continuum of Care, the VA, as well as some consumers. In fact, a couple of weeks ago, I went to our Ryan White Consumer Council meeting and told them that we were going to be working on this project and wanted to invite them to participate so we could get their feedback. There was a lot of enthusiasm. They were very passionate about it. I think many of them had experience with housing services, some positive, some not so positive. So they were very excited that we were doing this and were eager to participate. The goal of the community planning component is really directly related to the National HIV/AIDS strategy, and that is to make some strategic improvements in our local housing delivery systems to increase the percentage of Ryan White clients that have stable housing, which is directly reflected in the strategy. In our area, Hopwood touches about 1,000 people living with HIV and AIDS in some way. But there are almost 9,000 Ryan White clients, and we have needs assessment data that says about over 4,000 of those have housing needs, but we don't know where they're at and who they are. And so that's going to be a big part of this process, to bring those partners together to kind of organize around 4 planning teams, which is actually loosely patterned after the 100,000 Homes campaign. that's a very action-oriented, direct approach to housing, centered on housing. So we wanted to take that approach, but then also kind of overlay the strategy as well. So we're going to be organizing around 4 planning teams, HIV housing demand, where we'll look at determine who's most in need of housing, how do we identify them, how do we put a face with them, and then how do we prioritize their needs. Then also looking at housing supply, even going beyond HOPWA, beyond the housing authorities, to look at affordable units, other subsidized units, to really research and catalog those resources and find ways to educate and inform both clients as well as our partners about those resources. Third is housing connections, which is kind of bringing that supply and demand together, and really looking at some innovative tools for housing planning, some web-based ideas, maybe some housing labs where clients can get housing information. And lastly is housing stability, where we're really going to be looking at really focusing in on our primary prevention efforts, and specifically the HOPWA short-term program, but also other prevention programs in the area, and how to interface with Ron White services, mainstream programs, as well as some income initiatives and employment. Then kind of overlaying that housing focus is we'll also look at the national strategy goals, access to health care, HIV prevention, and eliminating disparities, to see how housing can fit into those efforts in our community. And also, we talked a lot this morning about systems integration. That's definitely on the list in terms of looking at our state ARIES system and our local HMIS. So we're ready to get started. We have our first meeting that's scheduled for December 9th. Everyone's really excited and enthusiastic, which kind of scares me a little bit because this is a 3-year process. So, you know, kind of my charge is to keep the energy and enthusiasm up for 3 years. But we'll give it a shot. And, you know, I think everyone's very excited to work on the project. So thank you.
Hi, I'm Glenda Penny from the Los Angeles County Commission on HIV, and our project title is the Collaborative for Housing Integrated with Supportive Services, or CHIS, as we like to call it. And the Los Angeles County Commission on HIV is the Ryan White Planning Council for the Los Angeles EMA, and the commission is the grantee for this SPINS grant. The project sponsor is the Alliance for Housing and Healing, which is a nonprofit that provides housing and other services for both HOPWA and Ryan White clients and homeless clients as well in Los Angeles. There were 6 partners in this collaborative: the Commission, the Alliance, the Los Angeles County Office of AIDS Programs and Policy, which is also the Prevention Planning Committee, the City of Los Angeles Housing Department, the Housing Authority of the City of LA, and the Los Angeles Homeless Services Authority, which is a city-county joint powers authority. So the partners are both city and county government agencies, and for those of you who don't know LA, city and county don't really talk that much, so Mark, you're probably familiar with that dynamic. And so we were very pleased that the city and county came together in a very short time to apply for this SPINS grant. Our target population is low and very low income persons with HIV in their families who are homeless or at risk of homelessness, who are either newly diagnosed, so that's an HIV diagnosis within the last 3 months, who have been never in care, and surprisingly there is a population in LA. When we did a needs assessment 3 years ago, we found that 5% of the respondents out of 700 knew they were positive, had received a diagnosis, but never received medical care for their HIV, or have been out of care for at least 6 months. So what we're planning to do with the HOPA SPINS funding is to master lease scattered site units in the city of Los Angeles. We'll hire a full-time service coordinator for the CHIS clients. We'll coordinate funding and services and then develop the integrated HIV/AIDS housing plan. The CHIS participants will be eligible for permanent housing placement assistance under the HOPA formula grant to help them pay for the rental application fees, credit reports, and for utility and security deposits. Clients will also receive up to $1,000 towards the purchase of furniture and other essential items that will be paid for by private donations when they move into housing. Over the 3-year period, 50 households will be served over what we call 2 overlapping cohorts. And the 25 clients will be served, will move into housing by month 6 of the first year, and the second 25 households will move into housing 6 months of the second year. And during the first year of the HOPA SPINS grant, all clients will receive housing assistance and service coordination through their SPINS grant. And then after the first year is completed, the clients will be responsible for paying the full amount of their rents if they're gainfully employed, or if not, they will be transitioned into other housing that's appropriate for them, such as permanent supportive housing or the Section 8 Housing Choice Voucher Program. And during the 3 years of the SPINS grant, clients will be able to receive medical outpatient services, mental health services, oral health services, and medical care coordination through the Ryan White program. On the collaboration side, the collaborative is going to build on its existing coordination and planning activities to conduct comprehensive planning and coordination of funding for housing and services for persons living with HIV/AIDS and their families. 5 of the collaborative members are members of the Los Angeles Countywide HOPA Advisory Committee, and one of the members is the director of the HOPA Formula Program. 2 of the collaborative members are HIV commissioners, and one is part of the commission staff. And so we hope that with overlapping plan and body memberships and staff, that the collaborative can advance comprehensive planning and coordinate public funding and services for people living with HIV/AIDS in Los Angeles County. So I was asked to speak a little about the Housing Authority involvement. And as I mentioned, the Housing Authority of the City of Los Angeles is one of the partners. And the Housing Department in LA, which administers the HOPA program, has a long history of coordinating with local housing authorities in Los Angeles County. And since the beginning of the HOPA program in LA in 1992, the housing authorities of the cities of Los Angeles, Long Beach, and Pasadena, and the County of Los Angeles have provided rental assistance to persons living with HIV/AIDS and their families. Rental assistance is provided to clients through the HOPA formula program for 1 year, and then clients are transitioned into the Section 8 program administered by one of those 4 housing authorities. And the Housing Authority of the City of Los Angeles also provides rental assistance to persons living with HIV/AIDS through the Shelter Plus Care program, which is coordinated through the Los Angeles Homeless Services Authority. So because of this long-standing history, 7 business days before this application was due, we reached out to the Housing Authority. I know, kind of risky. So we had a conference call. We didn't even meet in person. So there was the Housing Authority, the Housing Department, the Commission, the Alliance, got on a conference call, and basically we asked the Housing Authority if they would be willing to provide Section 8s for our clients once the HOPA SPINS grant ended. And they said, sure, how many do you need? And we said, well, just 50. We're only serving 50. And then they said, well, will we be getting any admin money for this? And I said, well, no, not really. And they said, well, okay. And so on July 28th and 29th, all 6 partners signed the MOU. We we were able to get them to sign the MOU, and because the Housing Authority was on board, so this MOU, as David pointed out this morning, it outlined the member responsibilities, how permanent housing was going to be provided, service coordination was going to be provided, and how we were going to conduct comprehensive planning and coordination. And so some of the lessons learned in this, really, it was a scarily 2-week process. That's how late we were sort of getting started in this. But because I think we had the relationships, everybody was very eager to work together and just do whatever was needed. You know, the commitment letters, the MOU, agreeing to, you know, leverage their own resources. And because of the nearly 20-year relationship that the HOPPA program has with the Housing Authority, it provided the foundation for this collaboration. And the Housing Authority really didn't hesitate to agree to provide the Section 8 vouchers, as I mentioned. And once they were on board, they were able to obtain city attorney approval to sign the MOU, and for them to sign the MOU in within 4 days. So that's what Los Angeles is doing.
Hi, I'm Jennifer Putnam. I'm the Director of Programs at Franny Peabody Center in Portland, Maine, and I have a bit of an opposite story, so this is good that we're going next to each other. For us, I think one of our biggest challenges thus far has been to really work with local housing authorities that are usually very small housing authorities and have long-standing boards, and to go and speak with them and really talk to them about how important it is that we feel this project is, and how we feel like it can be very significant for people living with HIV/AIDS in Maine. Our project is a statewide project. And so doing outreach to the rural parts of Maine, and many might consider all of Maine rural. Our largest city is 80,000, and that's the greater Portland area, not just the city limits. So we've had a lot of geographic reach to cover, and also a lot of, I would say, other kind of ground to cover as we've reached out to people. Franny Peabody Center already administers 3 HOPPA grants throughout the state of Maine. Okay. Sorry. We already administer 3 HOPPA grants throughout the state of Maine, and we're a Ryan White Part B provider as well. And so our goal with this grant application was really to try to provide a statewide plan for efficient service delivery for housing and for other Ryan White Part B and C grantees throughout the state. A lot of what we've found, we have more people on our HOPPA waiting list right now than we're able to serve right now through our 3 existing subsidies. So what we've really tried to do with this application is to maximize the subsidies that we're able to get, and also to be able to move people over year 1 and year 2, and then year 3 move them over into local housing authority, housing choice vouchers, and also other shelter plus care and other public housing. Right now we have 135 people on our waiting list, and we serve about 400 people living with HIV/AIDS in southern Maine. So that's really about 1/3 of our clients that are on our subsidy waiting list, and it's a 2-year waiting list right now for us. Our current collaborations are with all of the Ryan White Part B and C providers. We don't have Part A in our state, and we do tenant-based subsidies, as well as short-term rental and mortgage assistance. One of the unique pieces that we have encountered is that about 25% of our client base is now African refugees from Congo, Burundi, and Rwanda, some from other Central African countries as well, and that population is growing. And so we have different folks, including with refugee services, and different collaborations that we need to make in order to maximize services for those folks as well, many of whom speak little to no English, and most speak French instead. One of the things that we're very excited about is working with our Maine Housing Authority as well as other housing authorities throughout the state to come up with a comprehensive plan for people living with HIV and AIDS and to really connect them into mainstream housing services. And we're excited too because we feel like we can be a model for other rural states. I know a lot of, I've heard a lot of large cities, and I know the National HIV/AIDS Strategy really focuses on the 12 cities, but we have a lot of people in need in the rural areas as well and in the smaller cities, and so we're very excited about that. We have a housing coordinator who will be coordinating all of the planning and collaboration with other councils like the Maine Balance of State and the homeless councils in the area. And then we have an intensive housing case manager / service coordinator that will work with families from the beginning of this to the end of this, and they'll also work with other case managers in the Ryan White programs in the other part of the state. So they'll be co-case managed by our case managers so they don't fall out of service as well. I think our main goal really with this grant application was to be able to obviously free up people on our waiting list, but also to create a plan that's going to be a model for even other parts of our state that really have limited resources and limited staff that are able to connect people to housing in their area. And Maine has one of the oldest housing stocks in the country. It's very difficult to get approved approved housing that's safe and lead-free housing. It's a big challenge even when you find a place to be able to have it be not substandard housing. So our goal around that is just to reduce all those barriers to getting people stably housed. And after listening to a lot of other folks this morning, I feel lucky that a lot of our data is already able to be integrated in a good way, and we have such a small state that we're able to just ask for other measures to be put onto our Ryan White reporting system, and that's a fairly easy process for us right now. So I feel lucky about that, and I think that's about it. Thank you.
Hi, my name is Sue Bonkar. I'm the director of JRI for Housing and Client Services. You know, when we sat down to take a look at this grant back in July, or when it first came out, it seems like years ago, for crying out loud now, and we thought about the work that we currently do and what a difference we could make with future generations. Justice Resource Institute has such a terrific collaboration with many statewide partners in the state of Massachusetts. Right now, we are working with 400 households throughout the entire state that are linked to supported services and affordable housing, all coordinated through my office in Boston. So when we took a look at this grant, I approached our partners, which include the City of Boston, City of Boston Department of Neighborhood Development, the Department of Public Health HIV/AIDS Bureau, the Mass Department of Housing and Community Development, and our Ryan White program at the Boston Public Health Commission. And we thought, and based on some need that each of those divisions had seen, we thought it'd be terrific to put together a grant for young adults. So this program is all about working with young adults, ages 18 to 25 years old, with the hopes that we can bring folks earlier into care, stabilized housing, and then hopefully to graduate and move forward, whether into our existing programs or into a normal life. I mean, most people now that are, diagnosed do work and do have, unconnected to the necessarily HUD and other resources. So our goal through this grant is through the work of our service coordinator, Georgette, who happens to be here today, and is to coordinate that for these young adults with the link that every single person coming into our program must engage in some kind of vocational or educational program. That will be part of the program agreement that each of these young adults coming into our program will be associated with. So in doing so, we've engaged two sponsors to be part of this grant. The Regional Housing Authority that we work with in Boston all the time, Metropolitan Boston Housing Partnership. They will administer, I believe it's 15 to 20 HOPWA housing subsidies to the folks, to the young adults on this grant. We've also will go into a subcontract with the SPARK program. The SPARK program is a ticket to work program that the Boston Medical Center in downtown Boston runs for young adults with HIV/AIDS. We'll work with the existing partners as part of our other grants. We have JRI is part of what's called the Homework Project in the city of Boston, and we've been linked to vocational resources through there. We have a great resource with Mass Rehab for vocational services and educational services in Boston. So it's, quite simply, and if I can read my mission statement, our very last statement, my very last sentence of the mission statement, quite frankly, this is what we hope to accomplish. And our partners are committed to working with a whole new generation of young adults to bring them into care much earlier, stabilize their lives, and hopefully be linked to self-sufficiency. So that's it. Thank you.
Good afternoon. My name is Ryan Dybert. I work with the Portland Housing Bureau in Portland, Oregon. So we've gone from Portland, Maine to Portland, Oregon, across the continent. I'm very happy to be here and want to reiterate the thanks that many of our panelists have expressed to HUD for the opportunity to come and talk today. When we began looking at this grant opportunity that was provided through this NOFA, the most immediate place that we went in looking at our community's needs around HIV/AIDS and housing was to people who are currently experiencing homelessness or were at imminent risk of homelessness. We are very fortunate to work in a time when there's an excellent amount of both national and local data pulled together by excellent advocacy organizations like National AIDS Housing Coalition, who's with us today, that show us very clearly that HIV and homelessness are very, very closely intertwined. In the Portland area, we actually see lifetime experiences of homelessness among people with HIV around 16%, which compared to the general population at 2% is just a phenomenal disparity. And so when we started talking about who we wanted to bring together for our work, both to plan and to provide services, the folks that we saw at the table, my primary role within the city is as our continuum of care coordinator for our homeless services, and I also work to shepherd forward our 10-year plan to end homelessness. So it wasn't surprising to me, because of the link between HIV/AIDS and homelessness, to see that when we brought the folks to the table to begin planning for this effort, it was the same folks who were at the table to help us end homelessness generally. We're very lucky in Portland to have Cascade AIDS Project, which is a phenomenal AIDS service organization that has been very deeply, they're our primary HOPWA grantee, and they've been very deeply involved in our 10-year plan to end homelessness from the beginning. We're also very lucky, largely because of our work around our 10-year plan to end homelessness, to have excellent progressive partnerships with what I think is one of the most progressive housing authorities in the country, the Housing Authority of Portland, now named Home Forward. We were able then, in looking at this grant opportunity, to say, what are some of the innovations that we've been able to put together more generally in our work to end homelessness that we could apply more specifically for people living with HIV. And some of the, I think, best work that's come out of our 10-year plan to end homelessness so far is the development of a short-term rent assistance program operated by our local housing authority that was originally funded through a mix of federal, state, and local dollars, including home TBRA and a lot of local funding. Came to incorporate, it incorporated very well the homelessness prevention and rapid rehousing funds that came as part of the Recovery Act. And they also were able to take other Recovery Act funding particularly around labor, to begin a really innovative partnership with our local Workforce Investment Board to make sure that people who were coming out of homelessness through short-term rent assistance were being quickly linked to either benefits acquisition or to employment services through the Workforce Investment Board. And we basically took that model and ripped it off directly. It was an excellent model to build on that we could apply very directly within our HIV/AIDS service system. And that's made for, I think, two really exciting innovations that I look forward to over the next 2 years. One is taking that innovation of linking the workforce and short-term rent assistance into our HIV/AIDS system, and in turn getting the cultural competency and that our AIDS service organizations bring to their work into the Workforce Investment Board. And then the second innovation that I'm most excited about is to be able to take that work that we were doing specifically in Multnomah County, our largest county that Portland is located in, and expand it to the full 7-county metropolitan area that we work with through our Ryan White programs. So it's an excellent opportunity. We're very, very glad to be participating in it.
Thank you. Greetings to everyone. My name is Carl Falconer. I'm with River Region Human Services. We bring warm and sunny greetings from Jacksonville, Florida. Obviously, the weather did not follow us here. When we started talking about what we could do in terms of this funding that's available, what we basically looked at was the idea of us becoming, for lack of a better word, a good old-fashioned matchmaker in Southern terms. What we're going to try to do is bring people together. And we're in a unique position because we provide housing services and we provide housing services to homeless people, but we also provide services to people who are HIV positive. And so we're one of the few people in our community who actually do both things in both realms. But what we noticed is that a lot of the people in the system that were providing services to people who are HIV positive were not talking with a lot of the people who were providing services to homeless people and the housing in our community. So what we decided to do was take that role. The first step was, of course, to find a good match. And as I said, we're uniquely positioned as a member of both of the primary network agencies that we wanted to try to bring together. The first is the Emergency Services and Homeless Coalition of Jacksonville, which has about 65 members, mostly housing providers. And the second is our Ryan White Network of Care, which obviously provides services to people who are HIV positive. Again, we're one of the few member agencies in the city that's actually a member of both networks, and we know several people in both networks. The step two, of course, as any good matchmaker will tell you, is to enlist the help of friends. So what we did is we found some people who we could contract with or subcontract with, and one of them was Ability Housing, which is a major housing provider in Jacksonville, and we knew that they could help us in determining housing and helping us understand more about the housing and bringing in the housing partners. And the second was the Health Planning Council of Northeast Florida, which has worked with Ryan White programs doing several healthcare assessments in the area in Jacksonville. Step three was to get them to meet. And of course, in usual Southern style, the way that we do it down there is face-to-face, and it usually takes a long time. What we're trying to do is develop trust, and we're trying to develop relationships, and it's still as true in the South as it was ever, that you have to kind of meet and greet and drink some tea and say hi to everybody. And so that's our plan for that. The step four in our planning was to give them a reason to commit to the relationship with each other. And so what we did is we developed our program to house 40 families where the head of household is HIV positive. This is unique in our city and in our area because there is no housing set aside currently for people who are in families who are HIV positive. Unlike some of my esteemed colleagues here, our housing authority has not seen the light yet to be able to set aside those kinds of housing vouchers or set-asides for for families in particular or for individuals, but they're one of the people that we plan to bring into this also. And finally, again, step 5 is to start to develop the relationships of the families. Again, as any good matchmaker will tell you, it's not always just about the two people that you're trying to match together. It's about their families that you have to bring together. And so what we're looking at is all of the housing providers that we know personally because of the trust that we built with them, and all of the HIV service providers that we know because we built personal relationships with them, and how they're going to integrate into the entire system when everything is done. And finally, the culmination of the relationship, we hope, will be the individual or integrated HIV and AIDS housing plan that we're going to develop after 3 years. So ours is definitely going to be a process, and it's going to take us through the system. But again, 3 years we think is plenty of time for us to be able to merge everybody together and actually create an entire system of care where we can be that linchpin to bring it together. Thank you.
Oh, yeah, absolutely.
We're just going to switch.
Go ahead.
Thank you. My name is Nancy Chiarella. I'm from CARES in Albany, New York. And the project I'd like to talk about, I'll focus on the evaluation piece that we've incorporated as well as the employment piece. But CARES has a tradition and history of being a HOPA provider in our community as well as Shelter Plus Care and advocacy. We also are the COC lead in our community for 4 counties and the HMIS system administrator. So we were actually approached by the sponsors to be the grantee for this. So we were really brought into a model that was in the beginning, and why we were brought in was for our, I think, our COC and homeless work as well as our HIV/AIDS work. And the more they taught us about the grant, it seemed, and we're convinced now, is a good fit. So the partners for us, we're actually working in 2 cities, City of Rochester with Catholic Charities of Rochester, and in Albany, the Damien Center. And what's a little bit unique about us, I think, is we're going to be in 2 locales. One locale, Catholic Charities, has a history of being a HOPA provider. Our partner in Albany, sponsored Damien Center, has not been a HOPA provider before. However, they have a long-standing history of providing HIV/AIDS services, support, mentors, et cetera, in the community. So we have 2 unique sponsors to this program, but we're committed to delivering a similar system and doing some comparison. A strong partner in this effort that's been working in New York State and I think nationally as well is the National Working Positive Coalition. They've really influenced the model, which basically we're looking to introduce employment for the following reasons. One is looking at employment as attributing to positive health outcomes. We know about the housing, and now there's been some research. Dr. Liza Conyers, who's working with us as our evaluator, we want to look at how employment is affecting in a positive way to health outcomes. And additionally, they'll also be our evaluator along the way for continuous improvement process. The other partner through the National Working Positive Coalition will actually be a trainer who will train us on vocational rehab background. We, in Albany at least, don't have a strong relationship right now with Voc Rehab, not only through our COC, really, but also with the HIV/AIDS programs. So our intention, if you will, is each sponsor will have an employment housing specialist. The HOPA funds will be used short-term to enable clients, new clients, to enroll in vocational rehab programs, employment programs, or employment-supported programs, with the intent that we will graduate them to self-sufficiency at the end of the 3 years. We also, though, to make sure we're incorporating all of our HOPA providers in the community, because we have many in Albany as well as 2 in Rochester, we will also offer employment services to our current HOPA providers in the Albany Capital Region, which are 4, with the intent that we will not only bring resources to their clients, but also to train them on this model that we hope to replicate at the end of the 3 years with our existing HOPA providers. So although not the lead for this grant, they are very much part of the strong partnership. So we will as you've heard here today, be working at a micro level with the clients through the employment piece, but also at the systems level, not to duplicate what many of the partners have talked about, targeting the right partners, but we'll focus a lot of our energy on Voc Rehab and the WIB in order to address, well, first to see what are the services in our community, to make sure we're fully aware, to introduce them to the needs of our clients, as well as bring something to the table for them, which is persons who are interested in working, have wraparound support services that will contribute also to their business as good employees. I just want to back up that the story that led to this, not only the National Working Positive Coalition, but Catholic Charities in Rochester really brought the program to us in Albany via our strong partnership with the AIDS Institute of New York, that they've, over the last couple of years, they've been doing somewhat of a pilot of this program, unfunded pilot, but they were having clients coming in for HAPWA, and when they said, how can we help you, what do you need, the first thing many of the people were saying was they want a job. And that's really what drove this model. So our intent over the 3 years is to meet the needs of the clients presenting, to find the right employment fit for them, and to track that. So we will be relying heavily on the HMIS, the Homeless Management Information System. We will actually customize it with input from the evaluator on what data elements we're looking at. Our hope is to track the different populations that we're serving, ranging from youth who are new and have never been employed, to persons already in HAPWA, many who've been in HAPWA for a long time, to see, to measure, if you will, what type of employment as well as case support we've offered them, what the result was. Did they exit the program with hours worked? Did they get a job? As well as paying very careful attention to the benefits piece. We will also be training our case managers to be employment benefits specialists, if you will. We already know there's some concern with clients who say they want to work, that they're afraid of losing the benefits that took many, many years for them to acquire. So we hope to also become benefit experts and not only work with our clients to learn about the complex system, but with all the HAPWA case managers. So at the end of this, our hope is, one, when our HAPWA case managers are working with clients, employment is first and foremost on the mind, and not only in the HAPWA program, but for all the housing, permanent supportive housing programs in our communities, as well as to try to measure what works, what got in the way, and what can we change both systemically as well as at an individual client level with professional case management. Thank you.
Let's thank our guests for presenting those wonderful briefings on what they're doing in their communities again. Thank you. We have a little bit of time here, and we wanted to open it up to questions. If anybody has something they want to ask from the participants today. I have to say I heard differences in every community, but I also heard some common themes. Building from existing credibility of what you're doing, seizing the opportunity to think, what could I do better? What is needed? And then partnering with the organizations that can make that happen for special populations or special issues, resources in your community, thinking about others. Glenda, you're the only one who said you waited for 5 days out. I'm sorry, that's a unique thing. Sorry about that. Okay. I also mentioned HMIS, our data systems, and later this in December, on December 20th, we'll be doing a special training, a webinar on how HAPWA intersects with HMIS and can be used by our programs to help do client level. A VPI website will show that. You can register for that training. Thank you, Elizabeth. And again, sorry. Was there a question? No, sure, Nancy. Thank you for being with us today.
Thank you all for your presentations, and I'm excited about what you're about to do. Glenda, I wanted to get an understanding. I think I may have misunderstood. You said that people would be required after a year to move to pay market rents?
If they were gainfully employed. So there is an employment piece of our grant that I didn't mention, but we plan to work with the WIBs and also the local unions to, get employment opportunities for the clients. And so if they can't, then they will transition into the permanent supportive housing in the community or Section 8 as a safety net. And so there will be enough Section 8 vouchers for all the families, all the households that are served by this grant. In that same unit. And so that's why we restricted it to the City of Los Angeles, because we're working with the City of Los Angeles Housing Authority, not the county. Because in the short time that we had, we didn't reach out to the county housing authority. That just wouldn't, So, and because the City Housing Authority, we don't have to go through the Housing Authority Commission. We just spoke to the director of the Section 8 program, Peter Lynn, and just said, Peter, would you be willing to do this? And one of the things I didn't mention, but I should probably mention, is that in Los Angeles, the waiting list for Section 8 is 50,000 people, and it's closed. Like, you can't even get on the list. They only open it up every 2 or 3 years, and then everybody applies, and then you get on the list. So it's really exciting that they are able to allocate, the 50 vouchers for our clients.
Could I ask another question?
Sure.
To Lori? Can you tell a little bit about relationship with corrections? Are you working with people pre-release in terms of their ability to access housing?
I might have to ask Ruben to address that, because he is the manager of our vendor reentry. I do believe that they do some pre-release. Ruben, do you want to address that? And I think, Ruben, do you guys work with AIDS Arms that has a pre-release program? Yeah. And AIDS Arms is a Ron White provider in one of our central intake sites in our area. So they're one of the larger HIV providers.
Yeah, I have a question. I'd like to address it to Nancy from CARES. There's a lot of overlap between HIV and alcohol and substance abuse. I was wondering how you plan on tackling the substance abuse and alcohol abuse issues relative to the employment capacity building that you're doing.
Very good question. I can tell you at a minimum what we've talked about in our initial planning meetings, and this will really be driven by the sponsors themselves. Part of it will be, I think, twofold. At the client level, it will be to identify all the systems that the client may already be engaged in. Some will present already from a HOPA provider and linked up to services, and some may not. The initial screening and assessment, I think, are the tools that will determine who's appropriate for the program at the get-go and who may not be appropriate yet if the focus is on employment. So we haven't talked through the assessment tool and what would be the next point of referral, but at a minimum, it will be the case manager's role to see what barriers to employment the client themselves, him or herself, are facing, and to have those addressed one to determine if they're employment ready. So employment ready will have to factor that in addition to other factors they may be facing. At the systems level, our goal is through the continuum of care, as we're the lead agency for that, along with Orion White, to really make sure that they're a presence at the table. We know about the services in our community, for example, in Albany, but they're not a consistent presence at the COC table. Now, some of that's on us as the lead to bring them, but our goal would be to learn more about their services and to ensure that we have good coordination. One issue we'll have to really pay attention to is we have maybe multiple case managers working with one client, and instead of that being a challenge, our hope is that through good planning and teamwork, we can make it as easy on the client as possible. I hope that answered. We understand that's a barrier. It either has to be addressed at the get-go, but the assessment will determine if they're employment ready, given that barrier and where they are and maybe their own recovery.
Well, thank you, guys. And let me just mention one other announcement. And I want to thank Nurse Valdez and our health unit here at headquarters. On Friday, all day, we'll be doing HIV testing again at headquarters. And we're partnering with a community education group that did it last year. I think last year they were fully subscribed. 30 people were tested. And, really it gets back to that idea of one. It just takes one person to begin making a difference and to become tested if you're not tested, know your status. And, if you are somebody who is living with HIV, to understand the care that's there and participate in that. And I want to again thank our panel. Let me also especially thank again my two partners in this, Amy and Erica, because they really did all the great legwork and all the work on this. Let me thank them for the tremendous. Okay. And again, thank you everybody for joining us today, and have a great day.